Hi, everyone. Thank you for having me. That's bright up here. Is there any laboratorians out in the crowd today? Ben, you don't count. You're at my lab. Sorry, Ben. Okay. All right. Well, I'm going to take this second right now on this stage to do what public health does and just let you know of two things. A HON went out this morning that is about the fungal meningitis cases for individuals seeking surgical care down in Mexico. We now have a case definition, so if that applies to you, please check your email from that HON. If you have no idea what I'm talking about and it still applies to you, please talk to Dr. Ashraf here. He'll help you out. The other thing that I'm going to use this podium for is to let you all know that as of this morning, Tanzania has officially declared the Marburg outbreak over. So very exciting there. Yeah, very exciting. Also, I wanted to thank Julia for her great presentation earlier today. Much like stewards, most of the time when the public health lab calls, nobody wants to talk to us either. And they don't really like seeing our phone number come through. We're here to help. We really are. It's just we're the weird ones. That's when we get called. Yeah. So today I'm going to talk to you about the role of the Nebraska Public Health Laboratory in response to the increase in antibiotic-resistant microorganisms. I will keep it brief, especially since we don't have a lot of laboratorians here. We're going to do some quick overviews, and I'm going to get you to lunch as quickly as possible because I know that's the exciting part of the day. So today's objectives is we're going to summarize the role of NPHL in collecting and testing suspected resistant isolates, locate the position of NPHL, Nebraska Public Health Laboratory, and the larger antimicrobial resistant lab network, and I'll talk about what that lab network is in my slides, as well as describe the educational function of NPHL in response to antimicrobial resistance, specifically in the state of Nebraska. I'm also required to tell you I have no disclosures, nothing at all. I'm just a lowly laboratorian. So first of all, let's talk about what NPHL is. Dedicated to protecting the health and safety of Nebraskans through diagnostic laboratory science, technology, and education. That is our mission statement, and we achieve that goal through a collaborative relationship with the Nebraska Department of Health and Human Services. This collaboration constitutes a formidable effort towards enhancing the healthcare standards in the state. It also serves as a backbone for connecting private laboratories and healthcare providers to address public health concerns effectively. The Nebraska Public Health Laboratory conducts a very wide variety of testing. Like I said, we're the weirdos. We get called in when there's something strange or unique. So we do limited clinical diagnostic testing, and we take that all the way up from basic testing to high complexity analytical chemistry testing. The majority of the testing performed by the Nebraska Public Health Lab is to meet epidemiologic purposes. So if you think of Salmonella or E. coli, your clinical laboratories are the ones that identify that. Those specimens then come to us. We perform sequencing on it to be able to pair these together, especially when individuals are in close geographic location, to help identify those outbreaks so that we can go ahead and work with our DHHS partners to come in, mitigate, and contain that outbreak before spread continues. We also perform limited diagnostic testing. Like I said, we do SARS-CoV-2 testing, heavy metal quantitation, and high consequence infectious disease identification. We have a team of trained and continuously drilled individuals that are your response should there be a chemical terrorism or a biological terrorism event. And because of the work with those pathogens, we have a Tier 1 approved federal select agent biosafety level 3. It's a whole lot of acronyms I just put in there that we use for containment of these pathogens and safe working. We also have an educational outreach arm, which is Ben, my lowly laboratorian down here. He is now our educational outreach. And we aid in educating laboratories across the state of Nebraska in identification of these pathogens, but we also provide training, communication surveys, calls, whatever anybody needs in the areas of biosafety, safe identification, and of course, antimicrobial resistance. We play an important role in responding to the increase in antibiotic-resistant organisms because of that ongoing communication we have with those laboratories. We have calls with them frequently, and they rely on us heavily to work with our team, the HAI team at DHHS, to give them the most up-to-date information and guidance on what testing needs to be performed at their clinical laboratories and when they need to send it on to us. Confirming this antimicrobial resistance helps track resistant bacteria and ensures that healthcare professionals have access to essential information to aid in effective treatment decisions. So these are actually pictures we've taken from our lab, just shows you the variety of things. The top left there is going to be actually some drugs of abuse testing that we did that's looking at cystolytic trichomes under a scope. We have, of course, what you guys are all here about, some bacteria on a plate. And then every once in a while, they let me in the lab, and as you can see, it's really exciting when I get in there, and they just have to document it when it happens. So now, what are we all here about? Who has seen this or knows what this is? Good. In 2019, the CDC released a report titled Antibiotic-Resistant Threats in the United States. And this is a picture of the cover of that report. The previous report they had released in 2013, so after 6 long years, they decided to relook at everything and determine what are our threats that we're facing. And if you remember 2019, which was, before COVID, a long, long, long time ago, both some days seems like yesterday and some days seems like decades ago, before COVID-19 came along, everyone's concern was the superbugs. And that's what this report was highlighting. What are we needing to prepare for now that is going to hit us in the future? So this 175-page report highlights the growing dangers of antimicrobial resistance to public health and provides a comprehensive overview of the current state of antibiotic resistance in the United States. It identifies 18 different pathogens, both bacteria and fungi, responsible for causing serious infections in the United States. This report also outlines priority actions that need to be taken to address this threat, including development of new antibiotics, if feasible, improving infection prevention and control practices, better surveillance systems, and improving antibiotic use both in humans and in animals. I want to cover that because I know that's a topic that commonly gets forgotten. We need to look at the antibiotic use in animals as well and ensure that that's being done appropriately because many of our bugs can transfer from humans to animals and vice versa. As well as increasing or identifying the need for increased global collaboration. Of the 18 pathogens listed, they have them separated out into urgent threats, serious threats, and concerning threats. And we'll go into this report, not me, we're not gonna go through all 18 pathogens, it's okay, guys. This report goes into specifics of the 18 bacteria and fungi and explains why they made that list and supporting that with historical data. Obviously, of greatest concern from this list is the urgent threats, and NPHL has implemented testing strategies to address all but one of these. And then we also have implemented testing strategies for the serious threats listed. There is 11 total serious threats identified. Many of this is actually taken care of in clinical laboratories as a surveillance component, but NPHL has extended testing on these serious threats. And I'll go into the testing strategies here in a bit because my job is to tell you about the role of NPHL in this. But if we're looking from a sample standpoint, right, where does all of this start? It's going to start in local healthcare facilities, clinical laboratories, the people you all rely on to get you the data you need. They are absolutely instrumental in this process. We cannot be here talking about what we're talking about today if you don't have the data to show the resistance. You don't know what bugs are identified, and you can't get that information, we are not moving forward in this fight at all. So all of you, please go back to your facilities and thank your laboratorians. I will also use my podium for that today. Those are my people. They are very, very important. Thank them for what they do. So how does it work with public health laboratories? Local health facilities like hospitals like Nebraska Medicine, CUMC Bergen, Great Plains, for example, they are the first ones with these patient samples, right? They take them, they culture them, they identify them through biochemical or protein-based methodologies, and they do the susceptibility. And they start recognizing from the results of that susceptibility, something's a little off here. This is a resistant bacteria. or fungus, I guess. And they then start communicating with you all, but also with the state, because it is important to encourage that communication. We need to know what is happening across the state. If we have pockets of highly drug-resistant bacteria, we need to effectively respond to them, and if that communication does not exist, we cannot actively respond and thus prevent. So these laboratories are absolutely critical because they are getting that initial information out to the individuals who need it so that we can actively respond. We can go ahead and do some higher level testing in order to aid that patient as well as limit the spread of this potentially high concern pathogen. So then if we have a potential high concern pathogen, one that is resistant, it comes to us at NPHL, the Public Health Laboratory. So now I'm going to talk through a couple of the different things that we're doing for testing. Candida auris, you've heard about it already today. You're probably going to hear about it again later today. I believe I saw an antifungal outbreak later. Rightly so. This is very much a global health concern right now. I recognize that you can't see that map up there, so I'm so happy Dr. Ashraf had it on his slides earlier. But the important thing to note from that is that the colored states have identifications of Candida auris. And if you see Nebraska, we have none as of 2021, 2022. I will say we have seen a C. auris here in the state of Nebraska. It was in 2020. This map does not go back that far. Right before the beginning of the pandemic, CUMC Bergen decided to sprinkle a little fun in there. Thank you for that. But they did a great job and we were able to respond. But what concerns me about this map is that it almost looks like Nebraska is about to be engulfed there. How many of you believe this map is true and that we don't have C. auris in Nebraska? We don't have it, Matt? It's going to make your job easier if we don't have it, huh? We are all on the same page. We all believe C. auris is out there. We just are not actively detecting it. And one thing to note from this map as well is that majority of these detections are done from screening programs where they're actually taking armpit swabs or other locations and testing them for C. auris. This is not a map of the invasive cases, which are of greatest concern, but it is still of interest because those armpit cases can spread and become invasive in other immune-compromised individuals. So Candida overall is one of the most common causes of healthcare-associated bloodstream infections in the United States, and then you get these emerging strains like Candida auris. The systems are not in place to actively and correctly identify it. It is commonly misidentified, and I will say that your instrumentation in your laboratory absolutely has to be up to date. Dr. Ashraf also showed a nice little table earlier, which I didn't include because I didn't think there would be a lot of laboratorians here, about the different laboratory instruments and how they identify Candida auris. And the biggest takeaway from that slide is actually going to be, is your library or software version up to date? You may have an instrument capable of doing it, but if you do not have the correct version of library or software, you aren't going anywhere and you will incorrectly identify C. auris every time. And this is something that you actively have to monitor. I know a certain healthcare facility in the state of Nebraska who thought that their system was up to date. Turns out they were about 5 years behind. They had assumed that it was part of the annual PM process, and their field service engineer was not actively performing that update. Therefore, they were not actively searching for C. auris. NPHL does education efforts on this. We recently did a survey. Ben recently did a survey, sent it out to all the labs across the state of Nebraska and said, what method do you use? What version do you use? And we are actively working to try to get everyone up to date so that we can ensure that we are actively screening for this across the state of Nebraska. But if it is up to date, it will do a phenomenal job. You just have to make sure that it is up to date. The invasive Candida auris is really what we're worried about. About 1 in 3 patients actually end up dying. And there is actually some types of this Candida auris that is resistant to all 3 antifungal classes. So definitely a great concern. Since 2018, there has been an increase of reported cases of 318%. This is why this is a global health concern. This is why this is an urgent threat, and this is why Matt is pretending it doesn't exist here in the state of Nebraska. The other thing that we're working on right now is Neisseria gonorrhea. We actually are working on a pilot laboratory or a pilot study with various laboratories and clinics on this one. So Neisseria gonorrhea, we all know it's resistant. So the CDC actually put out in this 2019 report data that said annually there is 1.14 million new cases. And of those 1.14 million new cases, 550,000 of them are resistant to at least one antibiotic. Many of them are resistant to far more than that. And one of the problems with determining Neisseria gonorrhea resistance is that, much like C. diff, you don't commonly get a culture, so it's not easy to do that susceptibility testing. The swab that is taken is actually for nucleic acid amplification testing. And those swabs, once they're put in that molecular media, you can't grow a bug from them. You just can't. And getting a patient in for an extra swab, they usually don't like it. We all thought that the tickling the brain with COVID-19 was not fun. You don't want to get a gonorrhea swab twice if you don't have to. So it's very, very difficult to get culture and subsequent susceptibility from these individuals. But we are trying so that we can see where we are in the state of Nebraska with resistant gonorrhea. And so what's going to happen is at these pilot sites, we are going to get 2 swabs. One for the initial molecular identification. And I should step back and say, we will get 2 swabs from individuals who meet criteria. These are individuals who have treatment failure, who have residual long-term identifications of gonorrhea. And there is other criteria, and Ishrat can explain that if you're interested in that as well. She determines the risk factors as well. We will get those swabs in. The one will, of course, go for the molecular detection. We don't ever want to delay patient care. And the second will actually go straight for culture. We're going to do susceptibility testing. We're going to test them with those drugs right there. If it is pan-resistant or shows increasing resistance or resistance of concern, we're going to send it off to our regional laboratory, and I'll talk about those regional labs here in a second. And then no matter what, if that isolate grows, we are going to sequence it because there is a significant need for data that needs to pair phenotypic, so what we're seeing on susceptibility, with genotypic data. We need to pair this whole genome data together. If I can do whole genome sequencing and tell you a gene's there, and I can pair it with what I would expect that susceptibility to come out as, we can make great progress in this field, especially in the types of testing that does not result in culture. So of the 5 urgent threats listed by the CDC in 2019, 2 of the 5 were actually associated with carbapenem-resistant and Enterobacteriales. They changed the name, and it trips me up every time. And Acinetobacter baumannii. Those were the 2 that were listed. So we actually focus a lot of our work here. And to break down simply, we do 2 types of testing for these CREs to determine if they're CPEs, carbapenemase producers. You have the traditional phenotypic method. Some of your laboratories might actually be performing this already. Modified carbapenem inactivation method, MSIM. It is a culture-based method. It requires sometimes multiple overnight incubations. It is a manual read, and so you can have differences in technologists and how they're reading it. But it will determine most mechanisms of carbapenem resistance. I did put any there, but there are some things that can, of course, slip by. As with every rule in science, there is always a rule breaker. And then we do genotypic as well. We do a rapid molecular-based assay. Many of your laboratories also have it. Some don't. The Gene Expert Carba-R, it's an all-in-one contained PCR-based cartridge, and it does rapid molecular detection of the 5 main genes associated with carbapenemase genes. OXA48, VIM, IMP, KPC, and NDM, which I'm sure many of you here are very, very familiar with. If we get any type of isolate that is showing resistance, such as highly drug-resistant Shigella, anything you guys that is of concern, we also do sequencing. And there's multiple types of sequencing that can be performed on these. There's the traditional whole genome sequencing. It does everything, but it takes a long time to generate that data. And a lot of that data generated, we don't really know yet what it means. Like I said, we need to be able to pair that genotypic with the phenotypic. So right now, we're building these databases with this information so that we can learn from this information on a large scale moving forward. We can do targeted sequencing, where if we know specifically what gene we want to narrow in on, we can amplify that area and sequence that. And we can also do plasmid-based sequencing, and this is very important in the field of CREs or CPEs, because most of the resistance genes are actually located on the plasmid, and that plasmid can jump from bacteria to bacteria. And so we need to be able to look at 2 different species of bacteria, the plasmid with them, be able to analyze those and see if they are related and could have possibly jumped. So that is very important. We are not looking at the chromosomal DNA at that point. We are looking at the plasmid. NPHL also participates in the National Antimicrobial Resistance Monitoring System for enteric bacteria. Very long name. We call it NARMS. It's a collaboration among state and local public health, CDC, FDA, and USDA, and once again, there's those animals being thrown in there because we recognize the importance of having the agricultural community on the same level that we are. It's a collaboration among state, local health. Oh, I just read that. There is over 200 different laboratories involved with this collaboration. NPHL has participated since 2018, and we submit isolates quarterly as requested and by their definition of what they want us to submit. And these aren't isolates that we have previously flagged as resistance. What they are doing with this information is they are taking all of these, they are performing a wide variety of AST on everything we can submit. You can see what they're testing there. They're also going to perform that whole genome sequencing. They're also working on building that database, but they're taking it from the standpoint of, we don't think these are bugs of concern yet, but we want to monitor what's going on. We want to know how that genomic information is changing in case this turns into a bug of concern. And they're really looking at those resistance genes that I was talking about. So now we're going to get to the AR Lab Network. The AR Lab Network is a program from the CDC. This is actually based on the building blocks of the Laboratory Response Network. The Laboratory Response Network is what I spoke of earlier when I said I had a team trained for chemical and bioterrorism response. They took the ideas of having teams all across the nation that can respond to an emerging threat, and they put the antimicrobial resistance spin on it. It's a nationwide network of public health laboratories. It was established in 2016. And it is there to prevent and rapidly detect antimicrobial resistance and inform local responses to prevent spread and protect people. It is spanning all 50 states and includes 7 regional laboratories. And the goal of the AR Lab Network is to enhance detection for resistance tracking, identify pathogen-specific solutions, create public health strategies, develop better infection control guidelines, and prevent and combat future AR threats by working with state and regional labs to identify local transmission patterns and support outbreak response. The CDC plays a key role in the AR Lab Network by providing leadership, technical expertise, and laboratory testing support. So the regional laboratories here, as you can see, we actually fall under Minnesota. And if anyone knows anything about public health laboratories here, Minnesota is a powerhouse in the public health lab game. They are absolutely phenomenal. There are our area that in Central that we would send our stuff to if it is testing that exceeds Nebraska Public Health Lab's capabilities. We also send other things to them, such as non-Acinetobacter baumannii. So if you have an Acinetobacter identification that is not a baumannii, we send it up to the regional lab there in Minnesota. We do the same thing for non-Pseudomonas aeruginosa. What they are doing is they are looking at species that are closely related to organisms that we have already identified as a threat, and they are monitoring for developing resistance in those organisms. Pseudomonas aeruginosa, Pseudomonas fluorescens. Those two very well could start having identical resistance issues, and we already know that Pseudomonas aeruginosa is an issue. The 6 regional laboratories serve as hubs for local, state, and federal public health laboratories, and they provide technical assistance, training, and quality control for identification and antimicrobial susceptibility testing of clinically important bacterial species. Big thing here is they provide the technical support, they provide training. We actually have some staff going up to Minnesota next week for training. They train us on the new technologies out to aid in the identification of these emerging threats. And not only do they offer this training to public health laboratories, but frequently is extended to local healthcare facilities as well. So if someone in your laboratory is interested in attending one of these trainings in the future, please let us know. We would be happy to talk with them to see if they can support that trip at no cost so that you can have that type of learning in your own facility. Basically, they come into play when the local public health lab can't do it. I kind of think of them as their big brothers. We can't do it, they come on in and save the day. So the roles of the different things, we've kind of talked about this a little bit. Healthcare and clinical labs, they are our first line of defense. They aid in the surveillance because, once again, if they don't identify it or tell us about it, we know nothing about it. Without that healthcare and clinical lab section up there, this entire train of communication and samples would be lost. The public health lab, like I said, we do assist in detections and identification. We do a lot of the surveillance-based testing, and where we can't, the regional labs step in. They also train us and provide us the new testing methodologies and technical guidance, and the CDC oversees the entire program and fills in where there may be any gaps. So to have an example of what it looks like from a clinical lab, healthcare, a private facility, for the public health lab. So let's say this is a long-term care facility and you have an individual that we have isolated an Acinetobacter baumannii. And after susceptibility, we found out that this is a crab. I love that acronym. And so that carbapenem-resistant Acinetobacter baumannii is going to be sent to the public health laboratory. And we're going to do some testing on it, and we're going to find out, hey, that might be a carbapenemase producer. And so we're going to do some colonization screening, right? And so we test some individuals that it's been in contact with. And we find out 2 of these individuals have E. coli, and one has a Klebsiella oxytoca. And so initially, many of you may be thinking, well, they aren't related. Those are 3 different bacterial species up there. There's no way that this carbapenem-resistant Acinetobacter baumannii, I really should have chose better flow off the lips bacterial names here. There's no way that those are related, right? And so we do the susceptibility on those 3 other patients, and we find that one of the E. coli is carbapenem resistant, as is the Klebsiella oxytoca. But we have an E. coli in there that's actually a Shiga-toxin E. coli. It's not carbapenem resistant. It's not related in any way. So that person, we don't have to worry about. They are no longer part of the investigation at this point. And this is information that can be obtained from your local laboratories, most of it. And then it comes to us, and we do that molecular-based testing, and we see, oh, all 3 of these, even though they're different bacterial species, they all harbor the same resistance gene. They're all NDM positive by the initial rapid molecular test. Are all 3 of these related? We are very concerned at this point on what we're looking at. And so then we perform the whole genome sequencing at the Public Health Laboratory. And we actually see that 2 of these are actually an NDM1, and 1 of these is an NDM3. Now, this doesn't mean it's not concerning at all, that NDM3 E. coli. It means it is not related to the initial index patient. It means we have 2 separate investigations going on here. But what's important to note about this is that that NDM1 would never have been determined without a public health lab. That sequencing is absolutely critical to determine this inclusion and exclusion criteria when we're doing these outbreak investigations. And just having the initial identification of 3 different bacteria Could have been enough to have someone else say, no, this is not an outbreak. But because those plasmids can jump from species to species, that's what we're seeing here, where we had a plasmid jump from an Acinetobacter baumannii to the Klebsiella oxytoca. And we have seen this before. It is a hard one to tease out that information on, but it is very much doable. And we, even on the whole genome sequencing, the NDMs can have variation within them. So even two NDM1s does not mean that those are related. We actually have to do the analysis to confirm that the NDMs themselves are identical to ensure that those NDM1s are related. So for NPHL's education efforts, like I said, I've sat up here and told you all about the different testing that we do, but we can't function without those frontline laboratories, and so we spend a good deal of time with efforts towards education. We send out lab alerts frequently. Anytime there's something new, emerging, something we have to get out right away, we send out lab alerts, and we maintain a database of contacts of every laboratory across the state of Nebraska, and they love our mass emails, I'm sure. But that is important information in there. It's much like the HAN system that's already set up. If there's something that is critical that a laboratory needs to take into consideration, it is in that lab alert. We also do newsletters. We try to do them on a quarterly basis, and that is going to be more talking about upcoming things of concern. So for instance, we're working on a newsletter right now because we are getting into tick season. What do we need to look out with those vector-borne diseases? We send out laboratory surveys. I touched on this a little bit ago when I said we surveyed all of the labs across the state to see what their C. auris identification methods are, what version they're using, and then we can provide guidance if they need to get up to date to ensure that the screening that is happening across the state of Nebraska is sufficient. We have monthly statewide laboratory calls that our DHHS partners also hop on, so we can be a full source of communication for any questions or concerns for anything outgoing in the field, as well as touch on those topics we've already talked about. And I'm pretty sure Ben spends about half of his day every day with individual communication. If you have a bug with a unique resistance pattern, Ben is on the phone calling you, and that is the phone call that they don't like to see. What did I do wrong? What do I have to do now? But like I said before too, we also offer trainings. And if there is a training need that you or a laboratorian in your facility identify, please let us know. We will develop a training or point you in the direction of a training. Our goal is to have all of our laboratorians experts up to date and comfortable with what they're doing in a safe manner. So looking forward, I'm really excited for the transition that's currently occurring in many laboratory sections. Like I said before, it used to be very heavy on conventional microbiological techniques. They're very important techniques. They always will be, but because you are required to grow up that bug, sometimes they take some time. And you can get a lot of information from molecular techniques as well. That's what I was talking about with that whole genome sequencing. If we can sequence out every piece of information from that bug, how can we apply that? What we would really like to do is have sequencing used for clinical care. Many of you may have heard about the ethics surrounding sequencing and a variety of things. When you look at the entire genomic sequence of something, there are some ethical considerations. What if you find something that you weren't looking for? What is our responsibility in that realm? And so regulatory entities are a little cautious around sequencing right now. We are making headway. There are some that are allowing it for epi purposes, but what I would really like to see is sequencing used for clinical care. Can I get a specimen, sequence it, tell you what that resistance is probably going to look like, and can you use that information, therefore, to adjust patient treatment? We are working towards it, but like I said, we need that whole data information overload of genotypic versus phenotypic in order to make that jump into being allowed to use for clinical care. The other thing I'd like to see is same-day sequencing. When you do whole genome sequencing, which is what we generally have to do right now to get the information we need because we don't exactly know what we're looking for, it takes a long time. It can take about 3 days to generate that information, and then you have to do full bioinformatic analysis on it thereafter. Generates terabytes of data. So it's a lot to tease through to find the important information. Same-day sequencing, I would like Once we develop what exactly is necessary to look at to determine that resistance pattern, I'd like to do it in a targeted analysis sequencing standpoint. And NPHL actually is a beta site for a sequencing company that is looking at doing this. We are currently working with them on our HAI bugs and trying to identify ways that we can do same-day effective results. What I would like to also see is direct from specimen sequencing. This one's tricky. Like I said, C. diff and gonorrhea. Generally, it's a molecular test that is going to be sent out. It is direct from specimen. You guys are probably all aware of the idea of direct from specimen sequencing with COVID sequencing. You take that nasopharyngeal swab, the residual VTM, that goes on the sequencer. That works fine for very small viruses, but when you try to do whole genome sequencing of a very large bacteria, it gets very difficult to be able to get the quality that you need to get an effective read. We are working on it. We have some plans in place, some enrichment technologies that we think we can implement, but that is something we're looking forward to. And then wastewater surveillance. I'm very excited for this one. I know Dr. Osheroff talked on it as well. He's hopeful we get the funds. I'm saying we're gonna do it whether we get the funds or not. We have plans right now to implement C. auris screening in wastewater across the state of Nebraska. As you all agreed with me, we know it's here. We need to know where it is so that we can guide and educate the laboratories in that area to properly identify and screen and send it to us so that we can ensure that we don't end up with invasive C. auris outbreaks. We are also going to be doing KPC and NDM, and we are looking at other ones such as VIM, IMP, OXA48. Those are the big 5 that we're worried about with carbapenemase genes, but we're also going to hopefully expand to MCR1, CTM, X14, 15, and a variety of other things. So wastewater surveillance, I am very excited about, and I really think that we're gonna gain some great information that can be used in our antimicrobial resistance response. So at the end of the day, like I said before, when there's something strange in your neighborhood, who are you gonna call? NPHL? It's us. We have a 24/7 emergency pager. If you don't know what to do, if you have a bug that looks very strange, feel free to either call the HAI team at the state or call us directly and we'll get you in communication and we'll get a plan in place for how to respond to that. That is our 24/7 emergency number. We have the standard business number. Otherwise, Ben Ayers right down there, the state training coordinator, he is going to be the initial point of contact for most of our antimicrobial resistance work, or you can contact myself, Emily, lab manager. So if anyone has questions, I'm happy to take them. Hi, Kate.
Hi, Dr. McCutchen. I feel like this is the presentation we've been waiting 4 years to see from a planning committee perspective. I think you made a complex topic really digestible, so thank you. The question I have, my sense is from a lot of the infection preventionists in the room might be shy about microbiology. And so maybe could you give us a little primer? You're looking at a result, what will make you worry based on that kind of first clinical micro report?
So we have some great algorithms actually available on the NPHL website and the DHHS HAI team. We have generated these so that you actually can follow this algorithm down to determine exactly what you need to be looking for and at what point you need to be concerned. And this is going to be bacteria or fungus specific, right? Because they're going to respond differently to different antibiotics. So you need to look at what that initial ID was and then look at the susceptibility and follow that algorithm that way.
I think you just got yourself an invitation to a future ICAP webinar.
Okay.
So thank you very much.
I'll be there.